I'm very happy to have Professor Michael Nitsche in our colloquium series. So actually, Professor Jinung An and DGist, he invited Michael. So I would like to ask the Professor An to introduce about Michael briefly.
Okay, thank you, Professor Kim. Good afternoon, everyone. I'm really honored to introduce Professor Nitsche here today. So I'm happy to give a warm welcome to him. Today, we are extremely lucky to have the great lecture from Professor Nitsche. So I dare to say he's one of a great pioneer and brave explorer in discovering the neurological mechanism of tDCS and applying them to various clinical fields. Now I'm going to briefly introduce Professor Nitsche. He's director of the Department of Psychology and Neuroscience at the Leibniz Research Center for Working Environment and Human Factors in Technological University in Dortmund. He studied psychology and medicine at the George August University in Göttingen and received PhD in medicine at the MPI for biophysical chemistry in Göttingen. He is interested in plasticity research in humans, including non-invasive brain stimulation, neuropsychopharmacology, cognition, and application of non-invasive brain stimulation for treatment of neurological and psychiatric diseases. On the basis of much of grants from Germany and European Union, he has been actively conducting researches and publishing many prominent papers, more than 300 papers. Okay, without further words, I will hand over the microphone to the moderator, Professor Kim Tae.
Okay. Thank you very much, Professor An. And before we start Michael's talk, and I want to announce that I may have some problem of the Zoom 40-minute limitation. So if it is disconnected in some time of the 40 minutes, then please reconnect and come to the Zoom, the same address. So I will open it as soon as it is disconnected, but it may not happen. So I'm not sure about that. So this was an announcement. And so please welcome Professor Michael Nitsche for his talk.
Many thanks for the kind introduction. And it's a great pleasure for me to talk today about transcranial current stimulation, non-invasive brain stimulation tool to modulate pain in humans. I hope you can all hear me well and you can see the slides well, right? Okay, perfect. So why should we care about non-invasive brain stimulation to modulate pain and other neurological and psychiatric symptoms? I think the main motivation is that human brain physiology and task-dependent alteration of cortical activity and cortical excitability is a central factor in translating external stimuli into perception, cognition, motivation, emotion, other psychological processes, and then to translate this in behavior and motor activity. In studies in humans, we have learned a lot in the last 30 years or so by non-invasive, imaging approaches, functional imaging approaches, about the contribution of certain areas and networks to tasks. So I'll show you a few examples. It's a PET study showing activation of motor-related areas in motor learning, We have learned with EEG how oscillatory changes during task performance is here about working memory. And of course, fMRI has contributed a lot. So these studies show us which candidate areas are important for specific tasks. However, in most of the studies, you get correlative knowledge about the contribution of certain areas in task performance. And here for basic studies, but then also for clinical studies, if we are successful in modulating cortical activity and excitability or brain activity, here the stimulation comes into play, because in basic studies it can show you the causal contribution of respective areas. And of course, if respective symptoms are reduced or processes are altered in a specific way, you can think also about exploiting this knowledge for clinical application. And we have, as you all know, a couple of non-invasive brain stimulation techniques at hand currently, with which we can modulate various cortical physiological functions. You can induce activity via transcranial magnetic stimulation in your cortical target area. So via magnetic stimulation, you induce relatively strong, short-lasting electrical pulse, which is strong enough to induce activity of your target neurons. For example, if you stimulate the motor cortex, you can induce activity in this area, and then, for example, measure motor cortex excitability with motor evoked potentials, which you can see here. You can induce not only acute activity, but also plasticity, which means longer lasting alterations of cortical excitability and activity via repetitive transcranial magnetic stimulation, via combined stimulation of a peripheral nerve and your cortical target, and also via transcranial direct current stimulation, which will be the main topic of the talk now. And you can see here an example for a specific RTMS technique, which shows when you apply these protocols, motor evoked potentials are enhanced. So LTP light plasticity is induced, and with another protocol, and you see a long-lasting excitability diminution of your target area. And recently, techniques have been developed which are able to modulate cortical oscillatory activity, so with transcranial alternating stimulation, current stimulation, or also with random noise stimulation. So a couple of techniques are available. I will talk today about transcranial direct current stimulation, which is an electrical stimulation of the brain. And actually, electrical stimulation of the brain has been developed or has been applied since many, many years. So about 2000 years ago in ancient Greece, people used electrical fish to treat migraines, so also pain-related disorder. But this was not extremely successful. We have other options to treat migraine. About 200-300 years ago, people experimented with electricity to make blind people see, here to treat toothache. And I'm always not quite sure at this picture if this is a toothache which causes the problem with the patient, or it's electrical stimulation. However, so these were more or less phenomenological studies or applications of electricity to the brain. A breakthrough for human studies was a study conducted by Merton and published and conducted by Merton and Morton about now 41 years ago, where they showed for the first time that non-invasive electrical stimulation with 2 electrodes over the motor cortex could indeed induce activity of this area as measured by motor evoked potentials. So before it was more or less consensus that electrical stimulation is too weak to induce respective activity, but they showed that this is not the case. And you can say that this is the mother of all the stimulation techniques we use now in the field. So this was called TES with 3 big letters. The problem of the stimulation technique is that it's very painful, because these are high voltage electrical stimuli up to 700 volts, given for very short time, some microseconds. But you can imagine that you induce not only activation of your cortical area under the electrode, but also skin and so on, with all its pain receptors. And don't know if anybody of you received the stimulation before, but I did, and I can tell you it's no fun. But this was the basis for developing transcranial magnetic stimulation, which doesn't induce activation of these skin receptors and receptors of the meninges and so on. Well, that's an important study for the field. And another important study, especially for our stimulation protocols, were early animal experimentations, where it was shown already that weak electrical stimulation, so not as strong as with TES, induces neoplastic alterations of cortical excitability in rats in this case. Okay, so and we talk about tDCS, an important thing is that the stimulation techniques does not induce action potentials in the cortical target areas, but that's a weak stimulation. So we use in the classic protocols electrode size about 35 square centimeters and stimulate with 1 or 2 milliamp. So that's too weak to induce an action potential. But what you can do, or what you're achieving with this stimulation protocol, is that you modulate resting membrane potentials. So dependent on the stimulation polarity, you induce substrate depolarization of your target membranes or hyperpolarization. And since the induction of action potentials has a threshold, you can imagine that for a given neuron, for example, and you depolarize at the subthreshold level, you need less incoming activity to induce an action potential. When you have the other polarity over this area, you need more incoming activity. So you enhance or you reduce excitability of your target area. For this kind of stimulation, it's also important that it's not, of course, not homogeneous excitability enhancement or reduction of your target neuron. So the electrical field has to be oriented along the long axis of your neuron. And you can see here that the different compartments, you have D and hyperpolarization. At the end, the direction of the physiological effects depends on at which segment of the neuron you have which kind of polarization. The soma and axon hillock are more sensitive for electrical stimulation effects. So these areas likely dictate the effects you see of stimulation in a neuron. Respective studies with this weak electrical current stimulation has been conducted already in the 50s and 60s in animal experiments. You can see here a study of Lynn Bindman and colleagues conducted in London in slightly anesthetized rats. They stimulated the sensorimotor cortex of this area of these rats, and you can see here effects during stimulation. This is baseline activity without any stimulation. When they put the cathode over the target area, you can see that there's an acute reduction of spontaneous activity, whereas with anodal stimulation over this area, you see an enhancement of activity. You see also that this is no induction of activity, but you can see that here, this is spontaneous activity, which is up or down regulated, because you see here breaks, you see quite irregular patterns, bursts, and so on. So typical signs for spontaneous activity of your target area. What made this stimulation technique interesting for us were not so much the acute effects of stimulation, but that they found also already in 1964 that when they stimulate for prolonged durations, so this is here for 10 minutes stimulation, you can get long-lasting effects. You see here baseline activity, then stimulation with the cathode over your target area, and you can see that the activity of the target area is reduced. These effects last longer than 1 hour. And you can see here then that when they change the stimulation polarity with anodal stimulation 2 times here, you can see that there's an enhancement of spontaneous activity. In this case, these effects lasted for more than 5 hours after the end of stimulation. And if you think that alteration of cortical activity might have therapeutic effects in diverse diseases, then of course these are very interesting results. Okay, so we translated this about 21 years ago now to human studies. So you can see I'm a bit older now and have a bit less hair also. So that's our standard stimulation protocol for affecting excitability of the motor cortex. You can see that the electrodes are relatively big. We need 2 electrodes or head 2 electrodes here at the head, 1 electrode over the target, and then a return electrode. It's all not rocket science, so you need a constant current stimulator, not constant voltage. And we measured in our first study, and I will show you the first results of our first study in some minutes, the excitability modulating effects of tDCS with transcranial magnetic stimulation over the motor cortex and took motor evoked potentials as an index for the level of cortical excitability of this area. We first started with relatively short stimulation. So here we stimulated for 4 seconds, and immediately before the end of the electrical stimulus, we applied a TMS stimulus with the standard intensity. And you can see here that very similar to the rats, anodal stimulation enhances enhanced excitability, cathode stimulation reduced excitability during stimulation. An important aspect of this study was also that only a certain positioning of the electrodes, which induces an electrical field which is directed in a certain direction, induce these effects. So we tested other electrode positions also, but these were not efficient in inducing these excitability alterations, which makes sense. Then you remember the need for alignment of the electrical field to a specific orientation of the neuron to meet the long axis of your target neurons. Okay, so we had these acute effects, and then the question for us was, can we also induce neuroplastic long-lasting effects? Indeed, we were able to do this with prolonged stimulation. In this study, we stimulated between 5 and 13 minutes with 1 milliamp over the primary motor cortex. And you can see that there's an excitability enhancement, which dependent on the stimulation duration lasted for over 1 hour after the end of stimulation. 5 and 7 minute stimulation induced short-lasting effects, and these were massively prolonged via long stimulation with 30-minute stimulation. This study after effects lasting for more than 1 hour. This works also for excitability diminution. So when we put the cathode over the primary motor cortex, you can see here an excitability reduction, which lasted for about 1 hour after the end of stimulation with 9 minutes stimulation. Okay, so when you have these neuroplastic effects, of course, it's an important aspect to know what the physiological mechanisms involved. And we had some candidates. So since the initial effect is a polarization, we thought that there might be an initial impact also of voltage-gated ion channels. But since plasticity is primarily driven via the glutamatergic system and also affected by GABAergic activity, we thought that especially for the after effects, these transmitters might play a role. We did lots of pharmacological studies in the last years, looked also for the effects of neuromodulators on the plasticity effects induced by tDCS. I won't talk about these latter aspects today, but what I want to show you is that indeed we could show this block of voltage-gated ion channels via carbamazepine and flunioxazine, so a sodium and a calcium channel blocker, affected the effects of tDCS during stimulation, during this short stimulation, which doesn't induce plasticity. You can see that for anodal stimulation, which is expected to induce a subthreshold depolarization of neuronal membranes, you can see that the application of carbamazepine abolishes these effects as compared to a placebo medication condition, and the effects of anodal stimulation were also reduced via flunioxazine, the calcium channel blocker. We didn't have an effect of this pharmacological intervention of cathode tDCS, but because these are voltage-gated channels, then you wouldn't expect this because they are not open in hyperpolarized membranes. Another important aspect was that indeed for the acute effects, blocking of NMDA receptors, so a specific type of glutamatergic receptors involved in neuroplasticity, didn't affect tDCS effects at all, and we also didn't have an effect of modulation of GABA activity. So the initial effects of stimulation are polarization and depend on voltage-dependent ion channels. We were interested, of course, also in the physiological background of the plasticity effects of tDCS, and applied here stimulation under NMDA receptor block. Didn't see, as we expected, any plasticity induced under this pharmacological intervention. And we could also show that enhancement enhancement of glutamatergic activity and NMDA receptor activity via D-cycloserine enhances the efficacy of anabolic tDCS. So the after effects of tDCS depend on the glutamatergic system. They are slightly modulated by GABAergic activity. We didn't see here many or very clear physiological effects. Bit of a delay and enhancement under GABAergic enhancement with lorazepam. The explanation for these minor effects came some years later by a study conducted by Charlie Stack, a magnetic resonance spectroscopy study, where she showed that independent of the stimulation polarity, we get a reduction of GABAergic activity in our target areas, so with anaerobic and with cathedral stimulation. And since GABA counteracts plasticity, so this GABA reduction might work as a gating system to enhance the efficacy of glutamatergic plasticity. Okay, so to put things together and to explain also a bit more why we induce plasticity with tDCS. So I've shown you that we induce plasticity of the glutamatergic system. This is calcium-dependent plasticity. So when we depolarize neural membranes and we open NMDA receptors, these enhance calcium influx in the subsynaptic membrane. And it's known that depending on the calcium concentration, this results in removal or insertion of AMPA receptors to or from the subsynaptic membrane. High calcium concentration enhances the AMPA receptors. Low calcium concentration results in removal of AMPA receptors. So you can imagine that if you depolarize neural membranes here, you will get a strengthening of respective synaptic connections via insertion of AMPA receptors and vice versa. Okay, so I will talk mainly about neuronal effects of tDCS, but most of you might also know that the effects of tDCS are not restricted to neuronal systems. A study conducted by Monai and colleagues showed that we have, I don't want to get too much into details here, but you see not only an effect of calcium increase in neurons, but very prominent increase of calcium concentrations via tDCS in astrocytes, which regulate also calcium homeostasis and so on. So might be an important aspect of the effects of tDCS. And we get also effects beneath the neuronal effects on vessels. It was known also a long time ago based on animal experiments and also experiments at the skin level, that application of a tonic direct current modulates blood flow in vessels. And this is a study conducted in our laboratory some time ago. Asif Yamil showed that indeed there is an enhancement of blood flow. It's an fMRI ASL study, enhancement of blood flow with anodal stimulation under the target area, reduction of cathedral tDCS in the target area. And what you could also show is that the effects were relatively long lasting, so for 1 hour or more after the end of stimulation. So you get neuronal effects, you get effects on glial cells also, and you get effects on the vasculature with respect to blood flow. Most of the studies I showed you so far were studies in the primary motor cortex. For us, that's an interesting area and it's a nice model area, but of course, if you think about different diseases, you want to stimulate also other areas. And I want shortly to show you that indeed the effects we get in the motor cortex get similar effects when we do prefrontal stimulation, which is important for many diseases. We use TMS-EEG to show this. Here you apply TMS stimulus also over the head, and you measure evoked potentials, which are evoked via this TMS stimulus on cortical activity via EEG. And so we tested this for animal and cathedral tDCS. So this is how these cortical evoked potentials look like over the primary motor cortex. You can see that they look quite similar over the dorsolateral prefrontal cortex. Desmond Akbuada did this study and showed for different dosages of tDCS that there is the expected enhancement in MEP amplitudes. And when we look at the effects on cortical evoked potentials, you can see that there are different waves which are dependent on glutamatergic, GABAergic system, and so on. But what you can see here is that for the early waves, we get these excitability enhancing effects in the primary motor cortex. You get them also in the dorsolateral prefrontal cortex. So there's a relative enhancement of glutamatergic activity, a minor reduction of GABA activity. You can see for a bit later waves, and you can see here also for this later wave, which depends on glutamate and GABA, there's an enhancement of this activity. So this works relatively well. You can principally transfer the results, at least to a certain degree, from the motor cortex to other cortical areas. Desmond Mozayebi did the parallel study with Cassaville stimulation, and don't want to get too much into details here, but you can see when you look at the direction of these excitability alterations in the primary motor cortex and the prefrontal cortex, you get an excitability diminution, especially in the early waves. Okay, so I've shown you so far that beyond neuronal effects, tDCS affects also astrocytes, cerebral blood flow. For the primary motor cortex, MEP and TP after effects are comparable, and also these effects are principally transferable to prefrontal areas. Effects might be gradually smaller in different areas, so there are quantitative differences. We have, and that's, I think, the main information you need for your field of interest. We have talked currently only about regional effects of tDCS, so neuroplasticity and so on. And what's important is that you have not only these regional effects of stimulation, but you get also network effects. And this is a very early PET study where you can see already that the effects are not completely restricted to your target area. And then, of course, this could be caused simply physically by current flow, but also by functional connectivity. And I want to show you shortly two studies conducted by Rafael Polania. One study was resting state MRI, where we did resting state MRI before and after stimulation with anode stimulation, or with Cassaville stimulation, sham stimulation. And what we could show is that there are network effects of tDCS. So when we stimulated the primary motor cortex, you can see here that there's enhanced connectivity with the premotor cortex and also with parietal areas. And he did a parallel study in EEG, and we did here resting state EEG and EEG combined with motor task performance and 10 minutes tDCS, and again resting state and motor task performance related EEG. What he could show is that during resting EEG, not too much happened, but when we compared finger tapping before and after stimulation, you can see there's relevantly enhanced functional connectivity in the gamma frequency range. This could be, of course, also caused by repetitive finger tapping. So we compared here finger tapping after sham versus real tDCS. So that's a pure tDCS effect. And you can see that there's a bit less effect. So this is a compound effect of finger tapping and tDCS, most probably repeated finger tapping and tDCS. But you can see that the pattern is quite similar. So you induce not some kind of random functional connectivity, but this is task-related connectivity you induce with tDCS. Okay, so I've shown you here that you get not only regional effects, but also network effects of stimulation. So our question is, so we have these brain stimulation techniques, and how can we use them for the modulation of pain? And of course, pain is a complex syndrome. So this is mirrored by that you have manifold therapeutic modules to improve pain syndrome. So you have pharmacotherapy, of course, physical medication, physical medicine, rehabilitation. You have lifestyle changes, psychological support, alternative medicine approaches, and you have also interventional approaches, including neurostimulations, but also injections, for example. So brain stimulation is a component of these, or could become in future a component of these different approaches. You have a complex system involved in pain, so-called pain matrix. including a large number of cortical areas, including somatosensory cortices, of course, also the supplementary motor area, anterior cingulate prefrontal areas, amygdala, hippocampus, thalamic areas, insula, not to forget, and the cerebellum, and we have also different psychological components of pain, which are mirrored by the involvement of these networks, namely perceptual components, affective, cognitive components, and also vegetative components. So if we are thinking about treating pain with non-invasive brain stimulation, we should take these components and their cortical representations into account to achieve a targeted stimulation. To use brain stimulation as a treatment for pain, that this is principally possible was shown by epidural stimulation for pain therapy some years ago already, where it was shown here, for example, in this study conducted by Andre Obadia in 2014, that repetitive stimulation over weeks reduces pain syndromes after these effects are visible still after 6 months after initiation of the treatment, and in some patients up to years after the treatment. You can see here that before and when you compare before and after pain results, so higher values mean here that there's less pain. You can see that in many dimensions which are related to pain, the patients had relief via this stimulation technique. It's a stimulation, of course, with epidural electrodes, so it's a kind of invasive procedure. You don't have to open the brain, so it's not deep brain stimulation. Also, so you don't have to get to the brain directly, but it's still an invasive procedure. And the question is then, of course, could we achieve similar effects with non-invasive brain stimulation, with non-invasive brain stimulation approaches? And then, as I said already, the question is where to stimulate. So we have perceptual aspects, we have emotional aspects, and we have also vegetative aspects of pain. And so main networks include the sensory discriminative network and the emotional affective network. And then, of course, the areas which are involved in these effects differ also. So for sensory discriminative networks, somatosensory cortex is important. Motor cortex is also important. You might ask yourself, why is the motor cortex important for pain reduction? And this, of course, at first sight sounds surprising. But what is thought is that this effect is conducted via the connection between the motor cortex and specific thalamic nuclei. So thalamic nuclei, motor nuclei, which communicate with thalamic sensory nuclei, including the VPL. And so the thought is that this primary motor cortex stimulation via these areas reduces perception of pain at the end. And then you have the emotional affective networks, including DLPFC, but also limbic areas connected with medial thalamic nuclei, which are relevant for emotions and effects, and we feel when we perceive pain. So we have, for non-invasive brain stimulation, at least these two networks we can affect. Insula might be a bit more problematic for vegetative signs of pain because it's deeper situated. So this might be something for ultrasound stimulation, for example, in future. But these areas are candidate areas, and a couple of studies have been conducted here. So that's a study in healthy subjects with experimentally induced pain. They stimulated the primary motor cortex, primary somatosensory cortex, and also the DLPFC, and look for the effect on pain. So all the stimulations were physiologically efficient. You can see here a stimulation over DLPFC and primary motor cortex enhanced motor evoked potentials. And when you look at the somatosensory threshold, there was an enhancement of this threshold, so a downregulation of somatosensory perception with stimulation over the primary motor cortex, as the somatosensory cortex and the DLPFC. For experimentally induced pain, they saw an improving effect in healthy subjects with stimulation also over the primary somatosensory cortex, primary motor cortex. Also DLPFC, also here initially at least stronger compared to the sham stimulation condition. This was a non-active stimulation, sham stimulation. This is no stimulation condition here. And when they looked for heat-related pain, they saw also enhancement of threshold with stimulation over these areas they stimulated. So there is an effect of tDCS over these areas on pain perception at the end. And the question then is, of course, can you transfer this to these effects to treatment of patients who suffer from pain? I will show you a few examples which suggest that indeed this is possible. This is here a study conducted by Kedra and colleagues. It didn't apply the stimulation in patients with chronic pain, but in acute post-surgery pain after knee arthroplasty. They had 25% patients in the real stimulation group, 25 patients in the sham stimulation group. And the rationale or design of the study was that the patients got their surgery, and then after surgery, the patients were stimulated over 4 consecutive days, 2 milliampere stimulation over the primary motor cortex, and they had free access to lidocaine, which is an opioid pain antagonist. And they looked then for, and the idea was, if the stimulation reduces pain in these patients, they would need less pharmacological interventions. And indeed, this was what they showed. So before the first tDCS, there was after surgery there was no effect. But when you look then at the dosages of the pharmacological agent they needed during the next days when tDCS was applied, you can see that under sham stimulation they needed significantly more of this substance as compared to the condition where they received another tDCS over the primary motor cortex. So there was a relevant effect of tDCS on perceived pain in these patients, also against sham intervention. And also a couple of studies have been conducted for tDCS for reduction of pain in chronic pain syndromes. This is a study conducted in fibromyalgia, relatively old, as you can see here. One of the first studies where we conducted repeated stimulation over 5 consecutive days with 2 milliamp. Also, stimulation was conducted here over the primary motor cortex, but also over the DLPFC and compared to a sham tDCS condition. And what you can see here in the visual analog scale, where patients rated pain intensity, that another stimulation over the motor cortex reduced pain intensity, and this effect was so that they measured pain intensity always before and immediately after stimulation. But what you can see here is that the effects are they're cumulative over treatment days, and the effects were also present 2 weeks after the intervention. Importantly, in this study, the effects of motor cortex stimulation were stronger as compared to the effects of DLPFC stimulation, stronger as compared to sham stimulation condition, especially for the later effects. So it might be here that you might conclude from this study that stimulation over the primary motor cortex is superior. In a follow-up study where stimulation was conducted for 10 days, so they doubled the intervention duration. Study conducted by Valle and colleagues, also from the group of Felipe Fregni. You can see that the effects also here in these fibromyalgia patients were relatively similar. They had longer lasting effects for some weeks after interventions with NO-tDCS over this area. You can see here also, so DLPFC is the circle, that there were relatively short-lasting acute effects of DLPFC stimulation in this case. So it's not that stimulation over this area is not efficient. You can see this here also relatively clearly. So that's the time point T1 immediately after the end of this 10 days interventions. And you can see that here the effects are similar, but the effects of M1 stimulation are longer lasting at the end. And of course, fibromyalgia it's a tricky clinical syndrome, but the effects are not restricted to this syndrome. Felipe did another study in patients with chronic central pain after spinal cord lesions. And here you can see the same pattern of results. So here he did only compare sham with primary motor cortex stimulation. But you can see the 5 days intervention over the primary motor cortex reduced pain significantly. And these effects were at least trend-wise stable for some weeks after the end of stimulation. So we have currently initial evidence for therapeutic impact of tDCS on acute and chronic pain, but this is initial, this is preliminary. We have level B evidence for fibromyalgia, level C evidence for central pain after spinal cord injury, for example. For other syndromes, we don't have clear evidence. Currently, some mixed results. We have also sometimes heterogeneous results between studies, so it's not all clear. Most of the studies were small pilot studies, so we need larger trials in future to be more sure about the efficiency of this technique. We need a systematic evaluation of stimulation parameters, of course, to optimize stimulation protocols. So these were fairly standard protocols, and we need more knowledge about physiological effects of the stimulation to explore mechanisms. A few last words about this optimizing aspect, because we are working on this since quite some years. And that's a study conducted by Desmond Akbuara, and I showed you at the beginning that the effect of a single tDCS stimulation are restricted to a limited time course. And if you want to apply this technique clinical, of course, you need longer lasting effects. One option is to enhance stimulation dosage in a single session, so to enhance stimulation intensity and or stimulation duration. He did this here, comparing 1 with 2 with 3 milliamp stimulation between 15 and 30 minutes. And you can see here gradually enhanced efficiency of 3 milliamp stimulation as compared to the weaker stimulation protocols. So it might be that enhancement of stimulation intensity gives you better effects. Another option to enhance the duration of the after effects of stimulation is that you use protocols which induce late phase plasticity in animal experiments. Late phase plasticity can last not only for some hours, but also for days up to weeks after the end of stimulation. And it's known that you can induce this via repetitive stimulation. So, for example, 2 stimulation sessions, it's relatively short intervals. So the interval which is relevant for the induction of late phase plasticity is about 30 minutes long. If the interval is long in animal experiments, you don't induce this late phase plasticity. A study conducted by Katia Montesilva, I will restrict because we're a bit limited in time here to anodal tDCS. And we simply double the stimulation duration, and we didn't see so much prolongation effects, but we saw with a specific stimulation intensity even switch of the effects of stimulation. So only enhancing the duration of stimulation is not always the best idea. But when we had a short interval here, so this was 3 and 20 minute stimulation between 2 standard stimulation sessions, you can see that we get after effects which last for over 24 hours after the end of stimulation. So repeated stimulation with short intervals might be promising for enhancing the efficiency of stimulation. Has been not so far conducted in pain syndromes, but for example in patients with drug problems and so on, had some very promising effects. So repeated stimulation with short intervals might make sense. The long interval, we had here intervals of 3 hours and 24 hours, just 1 repetition, so not what we do in clinics, 5 or 10 days. You can see that the effects are, as compared to a single stimulation, for example, the effects are reduced. So if you want to stabilize, and this repeated stimulation with short intervals might make sense. And another area important for optimization of stimulation effects might be individualization of stimulation protocols. So we do neuromodulation with tDCS, which depends on brain states, of course, but also the amount of electricity you get to your target area depends on electrodes, target distance, of course, and so it depends on anatomical factors, cortical atrophy, or the size of the head. Asif Yami, in his study where he titrated stimulation intensity between 0.5 to 2 milliamp, explored the baseline excitability of his target area, the motor cortex, and has showed with TMS and showed that those subjects who showed enhanced baseline activity, so these are the light gray bars, showed better effects of stimulation with lower stimulation intensities, whereas those with lower baseline excitability profited more from higher stimulation intensities. And you can see here also that there's a bit of nonlinearity. So it's not that in those with high initial excitability, that stronger stimulation gave them even better effects. So it might be the case that individualization, personalization of stimulation protocols helps further to enhance efficiency of these techniques. Okay, so I've shown you here that tDCS is a promising neuromodulatory tool for the reduction of acute and chronic pain syndromes. Evidence is, however, so far preliminary for most syndromes. We need larger clinical trials for proven clinical efficacy. And what might be also important advantages for the future is to develop physiologically informed optimizing protocols to enhance efficiency of stimulation. This might include choice of target areas, stimulation duration, intensity, repetition, individualization, and also combination with other therapeutic interventions. I didn't talk today about this, but we know, for example, for the effects of anodal tDCS, that serotonin reuptake inhibitors and also noradrenergic reuptake inhibitors boost the efficacy of tDCS, and this can be also clinically relevant as shown for depression. Okay, so this was a bit a tour de force about tDCS effects, basics of tDCS and tDCS effects in pain, and these are all the people who are doing the studies, so you can see that we are quite international here. Many thanks for your attention, and I'm open for questions now, of course.
Okay, wonderful. Thank you for the great talk, and it was very informative, and probably the audience will have some questions. So please turn on your microphone and start to give questions.
Maybe I have a first question. Hi, Professor Nitsche. That's a lot of things to cover. First, you've done a lot of work, and it's just so impressive. And
thank you.
The question I, as a kind of a novice to this brain stimulation, I wonder, like, you experimentally shown that primary motor cortex stimulation has been like better in terms of pain reduction and some other parts. I still kind of do not understand why that's the case. I guess if you stimulate motor cortex, maybe your motor may have some jerk motion, or I don't know. So can you maybe have some insight or explain why that's the case?
So for the stimulation, over the motor cortex, you don't induce motor activities. So for this, stimulation is much too weak. What you can feel is some tingling sensations over your stimulation area, but that's the same motor and prefrontal cortices. I wouldn't say, I think we are really missing clearly systematic studies comparing stimulation of different areas with similar efficient fields at the target. So it looks currently that stimulation over M1 is more efficient than DLPFC stimulation. And there might be different reasons. So one reason might be that if you already reduce the perception of the pain, then you might have also reduced emotional effects of pain, right? So this motor cortex stimulation, this more tackles the perceptive part of pain, that you might modulate some more basic processes. This might be one reason. Another reason, or another point might be that, so when we stimulate the hand area of the primary motor cortex, this is relatively superficial. So you get this area relatively easily. For prefrontal stimulation, we get qualitatively similar effects, but we saw relatively reduced enhancement of TEP amplitudes, which might mean, independent from modeling approaches also, that you are not as efficient with standard stimulation protocol with prefrontal stimulation, which would then mean you might have to intensify stimulation. And then one aspect which might be also important is if you look at different stages of pain. If you have acute post-surgical pain, then there might be a predominating perceptive effect, which causes you the problems. If you have chronic pain syndromes, such as fibromyalgia, for example, then you have a growing importance of psychological aspects also, so of the emotional aspect and so on. And so it might be also the case that, dependent on the syndrome, different target areas are better suited, or even a combination to modulate prefrontal and primary motor cortex synchronously has not been done so far. We need a lot of studies to explore this systematically. So these are just initial studies, which I think show general promise in this technique for modulating pain. But this is what I mean with optimization, and so that's part of these approaches, of course.
Oh, I see. It's interesting that you've done so much work and you are still saying this is initial studies.
Yeah, I think so we have done a lot with basic physiology and pharmacology and so on, and done a lot of work with mechanisms. But if you think about clinical treatment, this was, if you look at the research done for the first 10 years or so, these were really mainly pilot studies in relatively small samples. And so one reason might be that when we are doing basic physiological studies, we work with healthy subjects, and this is not a big problem to get these and to start these studies and conduct these studies. When we do these studies, when we do patient studies, and I know what I'm talking about because we did one or two also by ourselves in our laboratory, it's much more tricky to get these patients, to get patients which are well suited and so on. And so it takes much longer time. So if you want to conduct a study comparing, let's say, titrating dosages and maybe also systematically compare different stimulation regions, then with our sizes of the hospitals and cities, this takes years. And then this declines, I think, motivation of many people. If you are in a big city, and that's one reason why many of these studies, for example, have been conducted in Sao Paulo, is that there are 14 million people there. And then it's more realistic to conduct these studies. So it's, I think that's partially a pragmatic question, but nevertheless, you will need, I'm deeply convinced that you need these studies, and these will be crucial if you want to get these techniques in clinical routine, let's say.
Thank you. So it's quite interesting. Still, like maybe motor cortex, because it's a surface, it might not be the other fundamental reason. And have you thought like comparing tDCS versus ACS, or do you consider, if not just surface, maybe some way, another way, there's interference way to target deeper inside the brain? Is there might be a chance to even get even more effective treatment?
So we are always thinking about this with different approaches. So interference might be a point. You have in an EU project we are in currently we are looking for the effects of stimulating of physiological networks. More likely, you always have network effects, but the idea was to reach deep areas via stimulation of different components of different components of the network, which are more superficially and so on. So I think there are different options, but one common shortcoming of the more conventional stimulation techniques currently is that you don't have really a direct access in humans with deep areas. Interference might be something for the future. Works nicely in mice, but mice have a relatively simple cortex, less folded, and so if you get the same effects then in humans, is something which would in deep areas is something which have to be shown. And I'm glad to hear to have an ultrasound expert here, and that's of course something which is. So it's also, I think this took longer to implement this than originally thought, and there's still some hurdles to overcome. And this would be, of course, very, very promising to have a selective stimulation then of deeper lying areas. And this might be, if you think about stimulation of the insula, or even maybe directly of thalamic nuclei, this would be a great thing. And I think that there are options, and there's hope for the future that we can achieve this. But also this will still take some work, I feel. Yeah.
Thank you so much.
My pleasure.
Hey. Yeah, thank you. May I ask you a question about the stimulation effect on astrocyte?
Yeah.
So as we know, the astrocyte is a kind of the non-electric tissue.
Yeah.
So I wonder what kind of mechanism is doing for the astrocyte to respond to the electrical stimulations.
Yeah, so I'm really not an astrocyte specialist, but what I learned is that there are also voltage gated receptors there, so it's not completely independent from electrical effects. And I read, I think 1-2 weeks ago, that there are also NMDA receptors which work as calcium channels in astrocytes, and astrocytes are also involved in calcium homeostasis. So it makes sense, even if there's not, of course, astrocytes are not electrically excitable, there are no action potentials or so. As far as I understood, they are still affected by these slow electrical, more or less tonic fields. And so this might be one reason why these effects are seen. If you see very similar effects in humans, I mean, these were slices. It's always tricky to say at the end of the day, because they use relatively high stimulation intensities. And if this translates to in which way this translates to the intensity range we use in our studies is something which is not so clear at the moment. And it's an interesting finding, and since they are involved in calcium homeostasis, this might be relevant component of the effects of stimulation. But research there is really, it has been described that there is this effect. What this means at the end, and what this means at the end for neural physiology and so on, is something which has to be explored as far as I see.
Thanks.
My pleasure.
So I have one question about the astrocyte-wise that's related to astrocyte. So you said that you are not expert, but I'm interested in the sleep, and to induce the sleep, from the ATP, from the astrocyte, ATP can be released by the glial transmission. And that ATP is broken down into adenosine, then it will induce sleep. So I was wondering that from your subjects who have done this tDCS, and do they have any feeling of tiredness or sleepiness after the tDCS?
Depends. So no, one thing is that it depends a bit on stimulation area.
Mm-hmm.
So, for example, with annual stimulation over the DLPFC, you can enhance attention and working memory stuff, and so you don't make them obviously more tired then. But when they are in our physiological laboratories and they just get the stimulation, we look for LTP, LTD-like effects. So they're sitting there in the chair for 2 hours or so. Every 4 seconds is TMS stimulus, maybe a bit tingling, but yeah, they shouldn't move. They shouldn't think about important stuff or whatever. So we need them in a stable state. And that's extremely boring. And then everybody gets tired somehow.
Okay.
And this is something that's an important thing, a very critical thing we have to control for our experiments, that they don't feel asleep. So tricky. But I would not exclude this completely. What we have seen, and we have recently conducted a study in early and late chronotypes and looked for effects on brain physiology and cognitive performance, and we tested in the morning and the evening. And so the late chronotypes perform worse and show less plasticity, tDCS-induced plasticity in the evening, as compared to the morning. Of course, it's vice versa with the late chronotypes. But for this reduced plasticity in the evening, then it's not exactly, I mean, it's not tDCS-induced tiredness, but I think there adenosine should play a relevant role. Yeah. So if this is downscaled, okay. Which is interestingly, it's completely, the effect you see is completely different from what you see during sleep deprivation. Mm-hmm. So we did a parallel study there, and then physiology looks different then. But adenosine might be interesting to study. Yeah, sure.
Okay, thank you for your answer.
My pleasure.
So any question, please feel free to ask questions.
One more question. Not to, you know, as sometimes we hear that there is ectopic pain generators in the spinal cord in the patient with chronic pain. Mm. So have you ever thought that the transcranial DC stimulation can be applied on the spinal cord? Is it possible technically?
It's principally possible. There are a couple of studies. Alberto Priori did I think, numerous studies in this field, transcranial diachron stimulation at the spinal cord level. So they describe physiological effects. There are also some animal studies who have done similar things, but we know less about the physiological background as compared to brain stimulation. But it's possible, and you see effects of the stimulation also when you do spinal cord stimulation. Yeah.
Okay, I have a question. Thank you for your great talk. I'm curious about stimulation optimization. For this, you mentioned duration, intensity, repetition, and target location. So if we can monitor the brain states in real time while stimulating at the same time, I think we can optimally control stimulation, target location, as well as other parameters. And I'd like to hear your opinion, if you think these methods will be possible or valid.
I think it depends on stimulation techniques. So so at the end we talk about closed loop approaches, right? And I avoid this a bit because this terminology faces an inflation currently. So in 90% of non-invasive brain stimulation studies where it's labeled closed loop, it's state-dependent stimulation. So you have a state before stimulation, then you do the stimulation. And for closed loop, you would need a dynamic adaptation, of course. So in principle, it depends, I think, on the technique. So with tDCS, it should be possible because you have a tonic current flow, so it's not such a mess. There's a problem, always a problem of noise, but it should be not so problematic. For oscillatory stimulation might be a bit more problematic because there's currently no technology developed which really avoids that. You have this noisy aspect, and then your main interest will be adjustment to spontaneous oscillations. So I think there's a way to go, but some technological problems can be solved, has to be solved before we do it. The other thing is, and for closed loop, you need, of course, a target so not target area, but let's say target effect. So brain is a nonlinear system, so you would need to know what's the optimum in a certain patient. And that's also not extremely trivial and might even differ between patients. But I wouldn't say it's not solvable. But my prediction would be it will. So we won't have a working closed loop system within 1 or 2 years in this field, because there are too many factors which we have to take into account. It will take some more time, but of course, if you think about clinical application and you want to have a system where the patient doesn't have to come every day or every second day, or you have to simply fine tune, so you simply repeat, then it would be ideal to have a system which is closed, which self-adapts itself. And I think this will be the future. The question is when the future comes. Also look for, when you look at other approaches. So by education, I'm epileptologist. And when you have a look at this this adaptive deep brain stimulations they developed or implemented for clinical routine some years ago. And it didn't work very well at the end, due to also different factors. So really due to identification of the pre-seizure state on more direct physiological signs, still problematic, and then do the stimulation inadequately. So yeah, I still have some 20 years to work, and so let's see how we end up. But I think it will be important, and at the end, that's the future. Yeah.
Okay. Thank you.
Thank you.
I have a very naive question, Michael. So it's a direct current stimulation. So why anodal and the cathodal stimulation has so different effect on the results?
Yeah. So if you take let's say you have a single neuron model or something like this, and then the electrical fields are antagonistic, and so it's the same section, same region of a neuron. With one stimulation, you will have, so you have to meet the long axis anyhow, so we'll have different areas of the hyperpolarization. Specific areas are more sensitive, which is in neurons, it's soma, and then it's axon hillock and so on. So you need less current intensity to modulate excitability in a way which is physiologically relevant. And then you will have antagonistically oriented electrical fields at the same section of a neuron. And so current influx, you will have substrate depolarization. With efflux, you will have hyperpolarization. And this is what you do with anodal and cathodal stimulation. When you take the model, the neuron as a model. Of course, we have, in humans, we have, always, because we have big electrodes, we look for excitability of areas. We have, if you break this down to single neurons, we will have also heterogeneous effects on the neural level, dependent on the neural orientation to the electrical field, which is not absolutely homogeneous, of course.
Yeah.
So extending to the question, that I have one more question. The cathode anode, should be paired always, or you can use only cathode and only anode?
So you need always current efflux. So you don't get, of course, you don't get current flow in the brain without two electrodes. Right. What you can do, because I think what is of interest for us is to get an effect of the anode without having at some other brain area an effect of the cathode and vice versa. So you want to have a homogeneous effect. There are some options. So you can work with extra cranial return electrodes. You can put your return electrodes at the arm or at the shoulder. There are specific electrode arrangements where you have one electrode in the center, and you have 4 return electrodes, which reduces current flow at the, or electrical field intensity at the return electrodes level, makes them functionally inefficient. You can enhance the size of the return electrode, which also reduces current density. And you can stratify effects also pharmacologically. For example, when you apply, co-apply tDCS with citalopram, then you won't get excitability diminishing effects of cathode TCS anymore. So it all gets in the direction of an excitability enhancement. So there are options to stratify directionality of the current effects.
Okay, so thank you for the active the discussion and the detailed answers. And if anybody has more question, soliciting some questions. And
I have one more question.
Okay.
So I've heard that non-invasive brain stimulation conference. There are many conferences in the world, and especially in Germany. So could you introduce some International NIPS conference for us?
So there is one which is now in December in Charleston. This was the brain stimulation conference organized by Elsevier and Mark George and so on, which was originally planned to take place in Kyoto and unfortunately couldn't take place there. So that's not Europe, but just one, that's December. And we have, there's the International Clinical Neurophysiology meeting, so the ICCN meeting next year in Geneva. Mm-hmm. This takes place, I think, sometime during summertime next year. And since Walter Paulus is the head currently, he has an interest to make there also make brain stimulation one of the major topics. So that's I think next year, if you think about Europe, and this would be a good option. And there's still, as far as I know, it's still also possible to submit contributions to it. So it's still open. And next year we should have a chance that we meet all in person again. I hope so, which would be great, of course. Yeah.
Michael, I have maybe last questions for you. So you've discussed a lot about this electrical stimulation, and our team of efforts are open to any type of stimulation in the brain. So I wonder do you have any comments on not only electrical stimulation, which I think is great and the most advanced and practiced so far, but there are other kinds of non-pharmacological stimulation, such as a ultrasonic transfer. And I think you've done some magnetic, or how do you think about maybe some other types of stimulation? Would that be equivalently good like tDCS, or do you have any expectation or perspective on another kind of physical stimulation methods?
I think there are many options, and I don't see these as exclusive. So I'm agnostic in this case. It's just we started with tDCS, and then of course I have most experience about this. But so for electrical stimulation, not on tDCS, we didn't talk about TSS, for example, today, which might be interesting for also modulation of oscillatory activity. We have recently developed a combined RTMS TSS approach with which we can induce and stabilize oscillatory activity, because one drawback of RTMS with respect to oscillations is you can induce it, but it's not very stable. With tDCS, you get stable activity, but it's only in training. So you need this activity already in the brain before you induce it. And with this combination, you can induce and stabilize these effects. So for static magnets, I didn't work personally with it, but the effects look interesting. I think it's a bit more tricky to modulate directionality of the effects, and the effects might be not very focal, but that's not necessarily a disadvantage. Ultrasound, I think it's very promising, it's very interesting, and I think we will see also that with this stimulation we will get regionally restricted deeper effects in future. We have to learn more about the physiology of these effects also, I think. But you see, it's more or less adjunctive. So with tDCS, you will never get selective effects, let's say in thalamic nuclei, if you stimulate over the head. Yeah? And with conventional electrical or also magnetic stimulation techniques, you will always have effects on the areas between your deep target and superficial areas. And there, ultrasound might be really a game changer. Yeah. Still needs work, I think, but that's how it always is. Yeah. But this could be extremely promising, especially if you think about deep brain stimulation now, and if this might change the field. Yeah.
Thank you so much. That's very exciting.
My pleasure.
Okay, so I think we need to conclude our colloquium today. So again, thank you very much for your wonderful talk and the discussion. And I think we had a very successful colloquium today. So I would like to give you the big hand, but we are not in the same place. So online big hand.
Thank you.